Hello, everyone, and welcome to the brand new WVU Medicine Children's Chats, a podcast from WVU Medicine Children's that covers everything you need to know about health for our kids. September is Childhood Cancer Awareness Month, so joining me to talk about everything you might need to know and about WVU Medicine Children's Cancer Program is Dr. Patrick Tomboc. He's the Division Chief of Pediatric Hematology and Oncology. Dr. Tomboc, welcome.
Thank you so much.
So I want everybody who's listening to get to know you. Tell us a little bit about yourself.
So I was born in Texas, moved up here when I was in training in Phoenix. That was actually going to be 10 years in March of next year. So coming up on 10 years. I think the thing that I talk about the most and honestly that I complain about the most are my four boys. They are a lot of ball of energy. We call them the Horde. They will terrorize anything, but they're sweet kids. They are currently 3, 6, 8, and 10. But it is the season of birthdays, so they're all about to have birthdays, and the numbers all change, and I'll mess them up for a while.
So you understand what parents are going through raising the littles.
Yeah, just I think it's I tell my wife it's much easier at home than it is at work than it is at home, just because it's so busy at home with the kids running around and all the energy, trying to get them outside and just trying to get them fed, clothed. If we can do feeding and clothes, we are winning, because otherwise it's just hard. Being a parent is one of the hardest things I do. I love my job, but being a parent is so much harder. Probably because of the emotional part too, but I'm thankful for my wife because I'm very lucky that I have her. And I'll say that a lot because she keeps them alive, keeps me alive. I tell everybody we really have 5 boys. She really has 5 boys. But I'm thankful for her. Other things, I like to be outside as much as I can. I've been cooking a lot. I don't know. I just try and keep. Right now it's kind of like I think every parent, you're in survival mode when you're at home, just making sure everybody's fed, and so that taking care of the kids preoccupies me a lot. But let's see, I've been here about 10 years. We've been growing the program. We are thankfully welcoming a new doctor to our group. Dr. Singh, she'll be starting next month, which is great. I think we are. It's just a busy job, and it's busy at home. So I just try and keep everything as copacetic as I can and try and get everything done. So yeah,
lots on the horizon for pediatric cancer care at WVU Medicine Children's. Yeah. So this is a very specialized level of care. It's a very difficult level of care. You're dealing with families oftentimes on perhaps the worst day of their lives and maybe the best day of their lives when their kids finish treatments. What's your why? Why pediatric cancer?
Yeah, I've thought about this so many times over the years, just trying to understand how, one, I ended up in this place, which I'm very thankful for, but also why I continue to do it, why I continue to pour, everything I have into it and try to do the best job and build the best program I can. And at the end of the day, really it's a amalgamation of wanting to take what is an unbelievably terrible and chaotic situation when a child gets diagnosed and make it less scary, make it more understandable, and make it something that the parents can help their child get through. That moment is just so much filled with chaos, so much filled with fear, loss, and just sadness. It is very important to, one, really bring people back from that like the edge where they're sitting, because the diagnosis is very much a life-changing diagnosis, right? In pediatric cancer, it's not always a life-ending diagnosis, but it's definitely a life-changing diagnosis. And in that, what the expectations that parents have and the hope that parents have for their child really evaporates. And that loss is palpable to the family, right? What they hoped for their child, what they want for their child, all of that is different. And in a lot of their eyes and a lot of the non-medical patients we diagnose, they think their child's going to die. The diagnosis is a death sentence. And I very much love bringing people back from that, bringing people back from this. My kid is going to die. Everything is terrible. This is the worst day ever. Bringing them back to a place where they feel they can help their kid get through treatment and get better. And for the majority of our patients, that's the situation. That's the experience. We diagnose a child, we figure out what they have, we start their therapy, we get them through therapy, and we finish therapy, and we get to celebrate with them. But it is very much a scary, horrible thing for families. The other part of this is the child. I absolutely love being able to help children remember they are kids. The diagnosis in and of itself is super frightening when you're 5 and your parents are crying and they're worried. You might have had a grandmother or an aunt or a cousin or somebody who had cancer, and you saw that they might not have survived their cancer. And so you're very scared. You feel terrible because you're sick, and you don't like the people who are supposed to be there to help you are finding it hard to control their own emotions, right? My oldest son, Max, had a stroke when he was a baby, and from that moment, I can't remember if it was actually one of my mentors or one of the pediatric neurologists, but they said a very poignant thing. Your child's not your disease. The child is not their disease, right? That is so important. It's so important for a kid to know, and it's super important for the families to know. They need to know that their child is still a child. Their child still needs to play, still needs to be a kid. They're not a patient. They're a child first, and we have to not only treat that child, but we have to celebrate that child and help that child play and be every ounce of a kid they can be as they're moving through therapy. And I think that's what is so very important about what we do, what I do and our staff does for these kids with cancer and their families. We help them navigate this very scary, chaotic moment and make it something that's palatable, that they can digest, and they can find purpose in helping get their kid better, helping them, deal with their nausea, helping them eat, make sure they get their medicine, make sure they sleep, all of those things that are super important in our care. They're able to, it literally empowers them to help take care of their children. I think that's super important.
Because it's such a long journey. Right. I mean, and I know from speaking with you and speaking with so many of our patients, and you mentioned it too, it goes sort of fast and furious when a child is diagnosed. Yep. But I want to talk first, sort of break it down a little bit for people who are understanding and may want to listen to this as a resource. The diagnosis, I mean, what tools are available to you and to providers to be able to accurately diagnose these children so that you know exactly what's wrong and can go straight in to start to treat it?
Yeah, there's kind of two kind of big groups that we kind of have to think about. The most common type of kids cancer is leukemia, or childhood leukemia. And that is, that's a cancer of the bone marrow that spreads to the blood and then is circulating in the blood. So that's kind of one group. And the other group are the solid tumors, or the brain tumors that are a conglomeration of cells that are all stuck together in one part of the body, being generated from one organ system or the brain, that kind of thing. They're kind of diagnosed differently. So the leukemic patients, which are our most common kids cancer, the therapy duration is about 2.5 to 3 years. The diagnosis is slow, and then it becomes very, very fast. So most kids with leukemia generally present with really benign, really like boring symptoms, like really common symptoms. So like they're a little tired, they're not running or playing as much, they might be a little pale.
Things that parents wouldn't look at and immediately say there's a problem.
Right. It's often how a virus starts, or an ear infection starts, or really any of the more common childhood ailments start. It's just, they just don't feel good, they don't feel great, they're a little punky, they don't want to eat as much. But the difference with like leukemias is there's always a progression of those symptoms. So they start with a little bit of leg pain, then it goes away, but then you get that leg pain that comes back and gets worse and worse and worse and worse over time. The fatigue increases, their lack of playing increases, and so you get, over the course of days to weeks, this kind of progression of symptoms, of worsening symptoms, where they just feel worse and worse and worse. When that happens, generally kids are brought to their pediatrician, which is the very appropriate thing to do. And if there are enough symptoms, something called a complete blood count is done. In the complete blood count, we get it's basically an assessment of all the pieces of, or all the cells that are floating around in your blood. The white blood cells are your immune system cells. The red blood cells are the cells that transport oxygen from our lungs to our brain into everywhere. And platelets are like little sticky balls that help us clot.
Is that where there's sort of like a trust your gut moment with parents? Like I hear providers say all the time, and my son's pediatrician has said to me, like, trust your gut. You know your kid, you know when something's wrong.
Right.
You know, it's always okay to bring them to their pediatrician and get it checked.
100%. And I think that is the most important thing. If you think your child's sick, always get him checked out. But if you see that progression of symptoms, the way that is diagnosed is that you see your pediatrician with symptoms and you see them again because those symptoms have worsened and worsened. And that kind of progression of symptoms that you can document and watch tells us how best to start looking for things. And that's what the complete blood count does. In the complete blood count, the machine literally looks for abnormal cells along with all the other components of the red in the blood. And if there is enough leukemia floating around, we'll catch a handful of cells in that CBC, and they'll be called blasts. What more commonly happens is that the progression of these symptoms of fatigue and tiredness, and then maybe even some bruising and little red dots, is that the leukemia cells are kind of filling up the bone marrow spaces where our red blood cells, where all our cells are made. And so as the leukemia kind of doubles and triples inside the bone marrow, it squeezes out the normal cells that would be making blood that helps transport oxygen or platelets. And so even if a very small amount of leukemia started, the CBC could show no blasts. But if the symptoms progress, so if you were tired and you're even more tired, the next time that you get labs drawn, you'll see that the hemoglobin is lower, you're anemic, the platelets are lower, or the white count is very low because the leukemia cells have crushed out all the normal cells in the bone marrow compartment. When that happens, that's when they get referred to us. And basically the way we've designed our clinic and designed our program is, if a provider or a parent believes a provider or anyone believes that there's a child who has cancer, we see them immediately. If we don't, usually within 24 or 48 hours. If they have abnormal labs, like if their labs are showing anemia, so a hemoglobin that's low, or thrombocytopenia, platelets that are low, and the white count's very low or very high, we will directly admit those patients to get that diagnosis as fast as possible. Because
is it a situation where time is of the essence? You know, we say that a lot in like emergency situations where minutes matter, but days and hours could matter with cancer treatments too, right? The sooner you catch it, the possibly better the prognosis is.
Right. So cancer cells divide rapidly. So if you think you have one cell, then you have two cells, then four cells. That's happening all the time. So if you have a leukemia diagnosis, you are generating more and more leukemia cells while we're sitting here talking. The most immediate risk is that those cells will expand, causing either organ dysfunction, or will get into the spinal column, into the brain. Those increase the risk factor and difficulty of getting rid of the leukemia. One of the bigger problems that we see immediately is if there's so much disease, or the more disease there is, the higher likelihood that when we start killing those cells, there's going to be an increased risk of what we call tumor lysis syndrome. And that's when we have these medicines that work really well getting rid of leukemia, but there's so much leukemia that when we kill those cells, what exists inside the cells, the electrolytes that are inside the cell, the cells kind of literally die and explode. And all those electrolytes spill into your blood, and your kidneys have to get rid of them. And it can really, really injure your kidneys because there's a lot of potassium and uric acid inside those cells. And those two chemicals can really injure and cause kidney injury or kidney failure. And so the more disease there is, the higher risk of kidney injury. And so the sooner you get kids in, the sooner you get diagnosed, the faster we can get rid of those cells and protect the kidneys.
I keep listening to this thinking how incredible it is the way treatments have evolved, like the way science has evolved, and the hope that that's brought for not just pediatric cancer patients, but any cancer patients, really. I mean, it's remarkable.
Oh, absolutely. I think one of the newest advancements in pediatric leukemia treatment is a medicine called blinatumomab that it did so well in its clinical trial that it was rushed, and the clinical trial was ended early so that the data from that medicine or from that trial could make it out to the public, so people in the world could start using blinatumomab. Blinatumomab is this really interesting, it's called a BITE cell. On one side, it has an antibody that binds a leukemia cell. On the other side, it has an antibody that binds an immune system cell. So it basically brings the two cells together so the immune system cell can eat the leukemia cell, right? it's an amazing medicine. It is now nearly standard of care, and that's in the last couple of years. The little annoying thing about it is you have to wear a backpack. It has to be infused for an entire cycle, so 28 days. So you can imagine trying to keep a backpack full of medicine infusing into a 3-year-old
on a little one
is really, really challenging. And they come up with really ingenious ways of breaking lines, breaking machines, breaking or uncoupling the hubs, all kinds of stuff. But the therapy is so effective and has shown such an improvement in pediatric cancer survival and getting kids into remission that it is right now most everyone is getting it, and it's amazing.
28 days of wrestling with your little one for a lifetime of doing it. Good trade-off.
Oh yeah, it is. It's just the story here just amazing, and every time they stop the medicine or every time the line gets broken, they have to come to our ER to fix, to assess and possibly restart the medicine. There's a whole protocol built around making sure we can continue the medicine as easily and safely as possible. But for our patients who live really far away, it's a challenge because if the infusion is stopped for more than 4 hours, there's a whole protocol of restarting it. And so it's proved to have some logistic challenges, but the study has such dramatic improvements in survival. It is absolutely worth all the silly little things we have to do to make sure it works well.
I'm sitting here listening to this and, I was prepared to have this conversation with you today. I knew we were going to talk about it, but I keep thinking of it from the point of view of a parent who is going to the doctor and has no idea they're going to hear your child has cancer and everything that comes after that. We talked about it earlier, but how important is it to involve parents, guardians, family members in sort of the day-to-day treatment, like for them to really understand what's happening, not just the doctor comes in, this is what we're doing, and the doctor walks out. Like your team really makes it a point to make sure they understand every step of the way. Like how important is that, I guess, for lack of a better word, from a morale standpoint for parents and those, who are supporting the child to really understand what's happening?
I think, unfortunately, medicine is a different language. Right, the things that I talk about, whenever a patient and a family is diagnosed, the first probably like 48 hours or 72 hours, they are hearing things they've never heard before. They're hearing words they've never heard before. They're hearing concepts they've never thought about or had to think about before. So it's very foreign. When you don't understand what someone is saying, I can't think of anything scarier, especially when they're talking about your child, right? If they're telling you, like, they're saying words you don't understand and they're talking about your child, that freaks me out because I don't know what's going on. I don't know how to help. I don't know what to call this. All those kind of like frustrating, that kind of frustrating situation. Having a family understand what we are doing as we are doing it not only empowers them to feel like they are helping their child get through therapy, but it also it lowers their stress. It lowers their anxiety when they understand what's going on. And I don't know, you have kids. Whenever our kids read us like sponges. So whenever a parent is crying or freaking out or screaming or whatever, the kid is in that exact state and they will mimic your mannerisms, your anxiety level, your stress level every single time. And so getting families on board with us, getting families to understand what we're doing and why we're doing it, it empowers them, but it also helps us. There is absolutely an ulterior motive for me to get families on board. When we send kids home, the parents are taking care of them. If the parents aren't informed, if the parents aren't educated, if the parents don't understand what we're doing, what makes us worried, what makes when they should call us, everything gets harder. Because we can't know that we don't know what's going on when they go home. We don't know if the family's going to call us whenever they have a fever like they're supposed to.
They're like another level of, they are caregivers, but they're like another level of like medical caregivers. No,
100%. That's why I love taking care of kids. I've got pseudo nurses and pseudo doctors going home with them, taking care of them when they go home, helping them get better and calling us when there's a problem. And because they're better educated, because they understand what we're talking about, because they know what anemia is and can look for symptoms, they call us before there's a problem, before the problem gets out of hand, before there's a bigger problem. And that is absolutely amazing because they're improving their child's care. They're making a difference in how long the kid's going to be in the hospital, how many transfusions they're going to get, all these different things. when they understand what we're doing, why we're doing it, when they understand or get a sense of when their counts are dropping and moving up from chemotherapy, all those things. The better informed the family is, the better on board the family is, the easier it is to care for that child. And I wish I had data on this, but I truly believe the better outcomes we get.
There's obviously a varying timetable to treatment depending on the type of cancer, the severity, et cetera. But I guess talk to us a little bit about is there like a general timetable, or like maybe a better question is, when is the point when a child reaches remission? Because we hear that word a lot. Yeah. It's a positive word, but like, when is the point when you get to that?
So remission is a really, has multiple meanings depending on where you're at. Remission in the hospital setting truly means we cannot see cancer. We cannot identify cancer in the sample or in the body. We can't find it. We can't see it. And I think that's a very important distinction from you have no disease. For things like leukemia, we're looking to get rid of every single cell, and there can be millions to billions of those cells in the body. We need to get rid of every single one, and there's not a scan or imaging or a test that can find every single cell. In leukemia, we say that people are in remission. The bulk of kids are in remission after the first 28 to 29 days. The majority of patients who present with B-cell ALL, which is the most common kids' cancer, are in remission by the end of what's called induction, the first kind of month of therapy, the first cycle of therapy. The way we diagnose leukemia is we do a bone marrow biopsy and aspiration. That's where our kids go completely to sleep when we do that kind of procedure, but they go to sleep and we basically sample bone marrow, which is like thick blood inside a bone. And usually we'll look at the pelvic bone and we go from the back because there's no organs or nerves or big blood vessels or anything, but that's where we go. At the end of the 28 days, that's when we do another bone marrow biopsy and aspiration, and we're really looking for response. We did a bone marrow in the beginning. We found leukemia cells, we identified them, got all this genetic data about them. And at the end, we do a bone marrow again and see how many cancer cells are left. What we're looking for is something called MRD, or minimal residual disease. We want to find the least amount of abnormal cells in the bone marrow. The lower the number, the better. We know we're not going to get rid of every single cell, but if we find one cell in 5 million, that's awesome. The lower number of cells we see, the better. And the MRD has prognostic significance. The lower your MRD is, the higher your survival is. And so in B-cell ALL, the MRD testing at the end of induction is generally when we consider people in remission if they have a good MRD or if their MRD is negative.
But that doesn't mean their journey's over.
Not at all. Unfortunately, we do know we can get kids into remission with our induction therapy, and we do it with the majority of kids. But we know if we don't do the rest of that whole 2.5 years of therapy, we know that the leukemia will come back. And generally when it comes back, it's harder to treat than it was initially. And so that whole process after induction is another 5 to 7 months of more intensive chemotherapy where we're giving medicines, some orally, but the majority of them are IV medicines that either go in through a port or a PICC line.
So they're coming to the infusion center.
Yeah, they come to the infusion center once to twice a week on varying schedules dependent on the type of leukemia they have. After the initial kind of busier phase of chemotherapy, there's a much longer phase, which we call maintenance, which is designed to decrease the risk of relapse. And so that maintenance period is a much more boring chemotherapy protocol, because within maintenance, your children are mostly just taking oral medicines at home, and we see kids about once a month. They get some IV medicines about once a month, and then they also get some spinal medicine every 3 months, kind of depending on what they have. But that whole process, that maintenance phase, is nearly 2 years of oral medicines and getting labs checked. At the end of the maintenance phase, that's when they complete their therapy. That's when they're done taking medicine, they're done getting chemotherapy. And from there, it's just a lot of watching. And so we do a lot of watching. We watch them for a minimum of 5 years.
There's always a really powerful image that you see with cancer patients is, when they get to a point, whether it's remission or finishing of their treatment, where they ring the bell. But at WVU Medicine Children's, we have the gong. Mm-hmm. And that moment is so beautiful. I've been a part of a few of them. You see these kids and their families, and it's a moment of relief almost. Like we made it to a big part of our journey. What does that moment mean to you and to your team to watch those kids, walk out of the infusion center, walk out of the inpatient unit and ring that gong and know they've reached a really significant milestone in their treatment?
I think the gong is just a really amazing and poignant kind of conclusion of this really harrowing journey for not only for patients, but for their parents, but also for our staff and for us as physicians. It is a long process for all our children. Even if their therapy is 6 or 7 months, it's still a long time to interact and care for a family, care for a patient. And we get a lot of touch points, and that's one of the things I love about this specialty is that we really, really get to know the families. We really get to know the patients. We really get to understand what they need, what they want, and how we can help them. But the gong is just this, it's just this gigantic.
It's huge for people who haven't seen it. I mean, I'm sitting down, but I feel like it's like up here. I mean, so like
it's the
massive.
Gong itself is like, I think it's like 32 inches.
It's not just like a little, like, you're playing cymbals in the marching band type gong. It's huge.
It comes with when I purchased it, it came with like this wooden hanging arbor. I don't know. And then I built a base for it so we could roll it around because we need to be able to move it to different places. We make
it a moment. It's a party. And, everything, you talk about how important it is to, like, you get to know these kids. I mean, your staff, they know what they like. They know if it should be dinosaur themed or, princess themed or we like race cars or whatever. I mean, there's such a personal connection there. And you mentioned it. It's because of the time. I mean, these kids are with you and their families are with you for years. And not only do you get to know them, but they get to know each other in a lot of cases.
I think that's so our infusion center is now 3 years old.
Almost.
Yeah, almost 3 years. Yeah, almost 3 years old now. When we designed the infusion center, we designed it with basically like a play area, a place where we hoped kids could organically go and parents could organically go to meet each other and play, because we're a very rural state, and a lot of these kids never meet another child who has cancer. A lot of these parents never meet another parent whose kid had cancer. They've never, they've heard of, they've had friends or relatives that had cancer, but it's an unbelievably personal experience, and it can be really isolating. We designed the infusion center so that there would be some level of literally organic connection where not only kids could find another kid that they could play with and another kid who was accessed or was connected to an IV pole, and in some sense normalize that experience, but also for the parents who are pushing that IV pole so the kids can go play in the play area, it normalizes that experience for the parents. They see another parent who's still trying to control their child, who's running around, who's attached to an IV pole, and they have to do this every couple of days, every couple of weeks, and it's hard, but they do it because they love their child and they're going to do anything for their child. And that kind of commonality, finding your people, I think that's a huge part of this, and that's kind of one of the things I love about our Camp Wanaka and Camp Hemavan. At that camp, these kids get to go and meet other kids who had ports, who had surgeries, who had to lose a part of their leg, who had been admitted for our kids who have AML or acute myelocytic leukemia. They are admitted for 30 days at a time. They get to meet someone else who had the same experience. They get to meet someone else who has the same scar, or who was, teenagers who were infantilized by their parents because there was this horrible diagnosis. The parents were just freaking out about what was going on. I mean, I think camp is beautiful in that it allows these kids to know that they're not alone and they have someone else who went through what they went through, and that's super powerful.
You need friends.
Yeah, absolutely.
So what's the future hold as you look at cancer care in West Virginia and the region, and how WVU Medicine Children's continues to grow to reach these kids? What's the hope for the future? What's the plan for the future? Because really, at the end of the day, what we want to give these kids is hope.
Right. So like short term, we're expanding our infusion centers so that we can allow kids to get the therapies they need closer to home. And I think that's super important here, and actually anywhere. It's really hard to leave your support system, your family, your church, your work. It's really hard to leave those locations to come all the way over here. And our families who come from the southern part of the state that drive 4 and 5 hours, it's not only time consuming, but it takes you away from work. It costs gas money and wears down your car and all those different things. So finding ways to deliver premium care at every WVU cancer center that has an infusion center for kids is our short-term goal. Probably the next 3 to 5 years. We currently have an infusion center opening up in Martinsburg, and we are working on one in at Thomas Hospital in Charleston. I think continuing to expand in that way so we can provide the care we provide here, but closer to home, is important. And I think the future right now is growing the program in its ability to continue like this level of care, but also to better take care of the behavioral aspects of therapy for the family and for kids, and to improve kids' quality of life as they move through this whole process, as they get admitted, as they get diagnosed, as they start therapy, and then through therapy, improving their quality of life and improving how they go through therapy is what I want to do and what I hope to do in like the next 5 to 10 years.
Well, Dr. Tomboc, thanks so much for joining us, and thank you to you and the entire team at WVU Medicine Children's that treats pediatric cancer for all the hope you're providing for families. It's a special calling, and I know how much the patients mean to you all.
Appreciate it. Thank you so much.
And thank you to all of you for joining us. If you'd like to learn more about WVU Medicine Children's or any of the services we provide to our kids, you can go to WVUkids.com. I'm Katherine Vey. Thank you so much for joining us, and we'll see you next time on the next episode of WVU Medicine Children's Chats.